Thank you, everybody, for joining us today for this presentation. This is a presentation for the Special Interest Group in Concussion and Mild Traumatic Brain Injury through the International Brain Injury Association. My name is Dr. Haley Chiswick. I'm from the University at Buffalo. I am a lead in our SIG, and I am very pleased to welcome in our speakers today. Before I get to their introductions, I do want to remind you all that there is an upcoming conference for IBIA in March of this year in Montreal. Abstract portals for posters and oral presentations are currently closed, but you can always register for the conference up to the day of the conference. So we hope to see you there, and we will have a meeting for our special interest group while we're in Montreal. So if you'd like to join, we'd love to see you. And without further ado, let me introduce our speakers for today. We have Catherine Forch. She is a physiotherapist from New Zealand who is currently a PhD student. Her research focuses on improving vestibular ocular motor examinations in concussed populations. She's also a lead at Access Sport and the director of Inner Level, which is a vestibular rehabilitation physio clinic. We also have Dr. Josh McGowan with us. He is originally way closer to me from Canada, but moved to New Zealand to do his PhD. And now he is a postdoctoral student at Matai Medical Research Institute. And his expertise is in MRI and other types of biomarkers. So I'll pass it off to Catherine, and I'll be back for questions at the end. If you do have any questions, please feel free to put them in the chat or raise your hand.
Sweet.
Cool.
All good. You want me to kick us off, Kat?
Yeah, go for it. Good morning, everyone.
Thanks for the introduction, Haley. I'm just going to do a couple quick slides, and then Catherine's going to launch us off, and then I'll wrap it up at the end. So we're based in little old New Zealand, and if you haven't heard of us, it's a little country at the bottom of the world. It's a population of about 5 million people down here, and a fun fact is there's almost a 5-to-1 ratio of sheep to humans. You might know that this country loves rugby, but it's sports mad across the sporting landscape, and we punch well above our weight in the Olympics on a regular basis. Unsurprisingly, being an island nation in the middle of the Pacific, we're pretty isolated, but out of that comes some good things, such as a culture that is known for making more with less, and a really collaborative environment where we know we have to work together in medicine and science to achieve our goals. So hopefully that's plugged throughout this talk. There's a pretty rich mTBI research landscape in New Zealand. We won't have time to cover it all, but just to give interested people a high level, there's a great longitudinal epidemiological study called the Bionic Study that's been going on for over 10 years down here. Development of new clinical assessment tools such as the BIST, which Catherine will talk about, research in the knowledge, attitudes, and beliefs, and how that's changing in the mTBI landscape, clinical pathways, physiological testing, both of which Kat will talk about, fluid biomarker research, and brain donation and brain banking work. I'll talk a little bit about some exciting work about exposure monitoring using instrumented mouth guards and the neuroimaging work we're up to. And while not relevant to this talk, worth at least noting that there's some pretty exciting work also in the space of large animal models of TBI involving tissue testing and histology, as well as some pretty advanced computer simulations. And so with that, I'll hand off to Kat to talk about the clinical side of things.
Thanks, Josh. So just for a little bit of context before we start talking about our specific clinic model, we have quite a unique, I guess, insurance situation in New Zealand where we have the ACC. So everybody who's on New Zealand soil has cover in the event of an injury. And so ACC put funding into prevention. They also pay for rehabilitation, and you can receive work-related compensation for your injury. So some of the issues around equity of access to care are mitigated by that, given that people can, particularly for concussion, can receive free care at a number of providers throughout the country. So I'm going to be talking about our clinic, but it's important to note that we're not the only concussion service provider in New Zealand. And just for a bit of context, we have about 36,000 concussions For the purposes of this talk, I'm going to use concussion and mild traumatic brain injury interchangeably. We're a very sporty nation, as Josh touched on, and roughly our statistics say that we have about 8,000 sport-related concussions a year, but there's an issue with the way that those are coded. So in New Zealand, only a doctor can diagnose a concussion for the purposes of ACC. So to write on the ACC form, a diagnosis of concussion has to be done by a doctor. So often if physiotherapists are the first point of contact for an injured person, then that injury will often be coded as a neck sprain or a facial contusion or something else that the physiotherapist can use, and they don't always end up having that concussion code added. So that 8,000 number, particularly in the sporting area where often sideline work, for example, is done by physiotherapists, that may be slightly on the lower side. So I'm going to talk a little bit about our service now at Access Sports Medicine. As Josh touched on, New Zealand's a very collaborative country, and so we all have our fingers in different pies, or whatever the metaphor is. So outside of my Access work, I do also do some consulting for some of our high performance sport organizations. But this clinic has been something that we've been kind of developing over the last few years, and so I just wanted to talk about kind of that process. So when we started, I got a phone call from a sport and exercise physician, and he said, hey, we've got this funding to start up a clinic, and we were fully funded by ACC, and our criteria was we had to see people within 10 to 14 days of a sports-related injury. So we had this very acute cohort. It was a really small team, so that was our whole IDT, was Stephen, myself, and we had Hannah, an exercise physiologist. And we were kind of tacked on to a larger sports medicine practice, and we were kind of in this funny rattling end of the corridor, and we had a little old treadmill, and away we went. And we started applying the principles of active rehab quite early on in the piece. So Stephen had followed the great work that's been done at Buffalo and some of the other centres that have been looking at this. And so we were really early into the idea of exercise tolerance testing people really early and trying to put people into buckets of symptomology so that we could start to target their management. And so now it's growing. So we see over 1,000 new mTBIs annually across 9 clinics. And so I guess lessons that we've learnt from growing the service from a very easy IDT model where patients would just come in and see Stephen and myself and Hannah, and we would chat, to what now works across a large team where we have access to a whole lot of different disciplines. We've got a fabulous physiotherapy team, we've got some awesome occupational therapists, and then we have an array of medical specialists that we can bring in if needed for that person's care. And so what we've tried to do as things have grown is take the parts that really worked from the old model when it was just me and Stephen and Hannah, and see if we can keep that kind of structure as we move through. The other thing that's been really cool as we've grown and the clinics have continued to sort of develop is that we've established all of these great research collaborations. So we are a really great option for people for recruiting participants for studies, and often our patients coming through the doors are really keen to be involved, and so we've had really great uptake in a number of exciting collaborations, some of which I'll talk to you about today and some of which Josh will touch on. So as far as some of our outputs within our Access team, Stephen published this paper a couple of years ago now as part of his fellowship when he was doing his sport and exercise medicine fellowship. And this was a cohort of that patients I mentioned with our early clinic model. So they were seen within 10 to 14 days of their injury. They were relatively young. So I think the mean age in this study was just over 20.2. And so we're looking at nearly 600 people there. And the reason I want to highlight this study is I still talk to my patients today around there's some misconceptions around their expectations of when they should be better. So this was a mostly male, so 3/4 male in this cohort, young, early access to care, sporty population. So if the deck is stacked in anyone's favor, it's going to be these folks. And so what we found is that at this stage, when we brought this paper out, there was a lot of the public's perception was, you know, concussion is kind of 7 to 10 days and then I'm better. And actually it was less than half were asymptomatic in that time. That started to grow when we got to the kind of 4-week mark, and by 8 weeks we had, you know, basically 94%, 95% of people were symptom free. And so I still highlight this paper that if someone's sitting in front of me and they've got a concussion and they're still experiencing symptoms at 4 weeks, or even for a non-sporty population at, you know, 8 weeks or beyond, I said, listen, this is the really expected time frame. Josh also had a little bit of a deep dive into what was it about some of the clinical presentations that was predictive of their trajectory, because that's always the $1 million question. I work with high performance athletes, and that's the first thing the coach asks is, when's this person going to be right? And this is not unique to this study. There's lots of work coming out of the Northern Hemisphere that showed similar things, being that female is a negative predictor, having a symptom cluster that's associated with the sensory motor space. So Josh found that people with primarily physiological issues or primarily cervical issues, they tended to get better quicker in this paper, and a high symptom burden is not a great sign if you're starting off with a high symptom burden. So Amitesh then had a little bit of a look. He's one of our sport and exercise physicians at actually the Buffalo treadmill findings. So because we do this on every single patient that comes into the clinic at their generally first contact, we have a really nice data set of a lot of tests. And there's a couple of things I just wanted to highlight out of Amitesh's paper. Now, this is much more recent. So this is essentially an update on the recovery timeframes paper. So if we look there, that people who got right through a Buffalo, so completed the protocol, were more likely to recover within that sort of 2 to 3 week period. So again, we're seeing that there's a link between their initial presentation and where they're going. Amitesh also found similar things to Josh's study, where if you were male and younger, you're more likely to recover faster. And again, if we look at those buckets of symptomology, people who have issues in the vestibular system and oculomotor, those kind of sensory systems, they generally take a little bit longer to get better. And I used to joke with the first paper that it was me. I was the negative prognostic indicator because I was the only person seeing our vestibular patients at that stage. But this study was across a range of clinicians. And as you'll be aware, it's not just our research that's shown that. So I don't think I'm the negative part. Now, this is a very busy slide, and I just popped it up here for a reference for anyone who is operating an IDT clinic. This is kind of broadly what our process looks like, because as we've shifted from Stephen and Hannah and I to this great big team, we've got to have systems and processes. And I know Nadir's talked to you about how they work through things systematically at Buffalo, but to simplify this slide, we essentially have 2 streams. So we have our acute sports pathway, where someone is trucking along, reasonably low symptom load. We have some early intervention. We get them set up with a plan, and away they go. But we do have the option for this much more IDT supportive complex concussion service. So in that, we have people who need, for example, clinical psychology, or they might have cognitive issues that need neuropsychological assessment. And so there's a lot more kind of wraparound care that's possible. And so we try and pick which stream people are in. But if any stage, if someone, for example, is in the acute sports pathway and things are looking like it's a bit more complex than we thought, we can hop them over and sort of escalate their care as needed. So it's this idea where we're intervening as much as is needed for that person, but we've got options in the background. So it's not that we are waiting until it's been 6 months after their injury and then they're still experiencing a lot of symptoms. And then we're kind of going, well, what's the plan from here? So I don't have time this morning to talk about the whole thing, but I just wanted to highlight a couple of bits on that slide that may be of interest or may be unfamiliar. So the first part is this BIST tool, which was developed by a group of us at the Traumatic Brain Injury Network. Alice Theodem has been championing this work, and those of you in the concussion world will be familiar with Alice's name probably. She's done some fabulous work in that epidemiological study that Josh mentioned, where they're tracking people through time to see their outcomes. But she's also spearheaded this work developing the BIST. So the BIST came out because of feedback from our local general practitioners who didn't have time to do a full SCAT and now what is now the SCOT in their clinics. So what was happening was that it was sort of in the too hard basket, and there wasn't any assessment being done. And so there were the genesis of the BIST was basically two things. One was getting some capture of their symptom burden initially, but also trying to embed some clinical decision making within the tool. So if you're not familiar with it, I'd suggest you have a bit of a look. Basically, it takes you through history, red flag, sort of anything that needs to be escalated immediately. And then it's about whether this person is going to need more supportive care. So this idea of layering, sort of triaging that person quite early on in the piece. And the other thing that the BIST does is sort of picks up people who might benefit from physiotherapy input early. So the other part I just wanted to chat about briefly is our physical systems screen. So obviously this used to be just me having a potter around in the clinic and Hannah doing a treadmill test, and now it's become a much more streamlined piece where we are looking at the different physical systems. Now on top of this, we also have our occupational therapists who'll be screening for mood disorders, and people do a cognogram and things like that. But if we think about the neck, we're looking at initially a mechanical neck assessment. We will then go on to have a look at sort of CGD and some sensory motor issues, but we need some mechanical signs to tell us if the neck's implicated in this injury, as we know a lot of concussions come with neck trouble at the same time. And then we're doing a balance screen, so that'll either be instrumented with valved force plates. We have those across our clinics, or sometimes we'll do a sharpened Romberg if those aren't available. And then we have Neuroflex, and our clinicians also will use a objective ocular motor exam and a head thrust sort of VHIT type thing, and BPPV screening if it's appropriate. And then looking at that autonomic piece, we also do a orthostatic hypertension. And then, like I said, everybody who comes into the clinic is having an exercise tolerance test. And that is been something that we've found to be incredibly valuable as far as sort of starting to unpack some of the pieces of the puzzle for that person. So I feel like we do the assessment piece pretty well, but then over the years, it's been this part that I've been a little bit kind of unsure about, which is this clearance for return to play, or kind of more broadly assessment of recovery. So what does recovery look like from concussion? Because as we'll all know, sometimes the goalpost shift, sometimes the symptomology is not clear, what's associated with the injury event or what's not. And so I think after the birth of my third child, I thought a PhD would be a good idea, and a fit of sleep deprivation. And I was thinking about kind of what I look at for return to play assessment with my athletes. And I want to be ticking off all of these boxes, basically. So what are the demands that they will need when they go back to sport? And how can we pick up some potentially lingering impairments that might be responsible for this big increased risk we see when people go back to sport after concussion? So that's where my PhD work was born. So I've got a fantastic team of very clever people who are helping me with this work, and I've got some support from the Health Research Council, so I'm very fortunate there. But we're looking at this idea of exertional testing. So we have shown in the clinic that the use of exertion is a really helpful assessment tool early on in the piece, and I have been using it as a sort of part of my return to play clearance for years, and it's not a new concept. Lots of people are doing this, but I'm trying to look at, are there some things that we can do pre, and then someone can do some exertion and then have a look at some post measures, and it's the difference between the pre and post that I'm interested in. So to start off with, to have a think about what this protocol should look like, I did a big systematic review looking at objective measures. So are there any objective measures that are different in people pre and post exertion who have concussion as opposed to healthy controls. And I'm only interested for the purposes of this in objective measures because of the issues that we know with subjective reporting. So some of my athletes are a little bit vague about their symptom experience for want of returning to play. But also we have issues in New Zealand with health literacy. So some people will be less likely to speak up about what's going on for them. And so I'm interested in what's some data. What are some things we can collect that doesn't rely so much on what the person's telling me as a indicator that they're recovered. And so my systematic review, we cast the net pretty broadly. So we were looking at people within a year of concussion who did some type of physical exertion. And I had the bar pretty low for physical exertion. So there's some studies in my review that used, for example, isometric hand grip. So basically anything that used skeletal muscle expenditure. So you could define it as physical activity as well. They needed to have a comparison group, a control group, and then I was looking at, like I mentioned, anything objectively that we could measure. I'm not going to talk heaps about the study. If anyone's interested, it's on Prospero, and it's out for review at the moment, so it hopefully should be published not too far away. But just to give you a bit of a snapshot of the results, so if we grouped the outcome measures that the papers looked at, there were 17 studies that looked at cardiovascular measures. So that's quite a big bucket, looking at kind of heart rate, blood pressure, heart rate variability, those type of things. We had 4 studies that looked at respiratory measures, 5 studies that looked at cerebral autoregulation. You could put this in the cardiovascular bucket, but I think it's a little bit interesting to look at on its own. And I was really hoping for some studies that were looking at balance and gait measures, but unfortunately there weren't any that met the criteria for my review. So there's been some papers, you're probably familiar with the exit test, the dynamic exertion test, where they look at performance of the test outcomes, but it's not actually pre and post. So it didn't meet my criteria for this review because they didn't have pre-measures, unfortunately. And then we had 2 papers that had looked at visual tests, so King-Devick and near-point convergence, and then 1 fMRI study and 1 looking at cortisol. But if we just have a look at the physical measures, because I'm cherry picking a little bit for the sake of the talk, prior to exertion, so this is in their participants in the pre-measure at rest, we had 4 of these 17 studies where there was some difference between the groups at rest. In the respiratory outcomes, we had half the studies, none of the cerebral autoregulation, and no differences in the visual study. So at rest, all of those participants and those ones looked the same. And after exertion, it's quite a different story. So we see the significant between group difference rise to 16 out of 17 studies. We see 3 out of 4 of the respiratory studies, 4 out of 5 of the cerebral autoregulation, and 1 of the visual studies showed a difference. So it's interesting, and it does answer my question, which is that is the hassle of applying an exertion protocol to your clinical tests worthwhile? Because I'm a clinician at heart and I'm looking at what's efficiency and what's the least burden to my patients and all of these things. And so I needed to answer the question, well, do we need to be using exertion, or is that just making a bit of a fuss where there doesn't need to be one? So yes, it looks like we do. The other thing that came out of my review is that similar to a lot of other work, we are seeing this gap between symptom recovery and physiological recovery. So 6 of the studies that had significant differences, all their participants were asymptomatic and they'd gone back to sport or were at the point where they were returning. So we know a lot about the autonomic nervous system, partly because of the fabulous work done by the crew at Buffalo and some other groups. But the sensory motor space is this big kind of unknown where we don't have a lot of information about the tools that we have available there. So that's really what I'm diving into now. I'm currently recruiting for this study where it's a randomized crossover. So people will attend 2 sessions, and at one of the sessions, they will have an exercise exposure. They'll also have 2 time points and 3 post-exertion time points. And our primary outcomes are in the sensory motor space. So we're looking at a bunch of different things. One of them is the Gait and Balance app, which was developed by a group of researchers at AUT. And it's a smartphone that you put on the patient's sacrum, and it can have a look at their postural sway measures. I'm also looking at that against force decks, so force plates. And then we're also looking at some walking measures. That's the benefit of the app, is that it doesn't have to be static like force plates, so it does take some measures while you're walking. The other thing that's one of my primary outcomes is this heartstrings measure that we've developed. And I've had some fabulous input from Hayley and Jake McPherson and some of the other crew at Buffalo to help us refine this. This is something I've used in clinic for a long time, but this is the first time it's sort of been entering the research space. So Hayley has been collecting some data looking at its value as a potential prognostic indicator pre and post treadmill, and we're doing that here in New Zealand too. But as far as my study, I'm having a look at it sort of change over time and what's the relationship with exertion. I've also got another study that I'm validating that measure. So against instrumented eye tracking glasses, what's the relationship there, so that it's really robust. We're also collecting some physiological data because it seems silly not to when you've got the person there. So I've got 3 time points where we're collecting heart rate variability. So there's a resting and then there's 2 post-exercise. And yeah, that's my bit. If you want to keep in touch with me, jump on LinkedIn is always a good one. I'm a total concussion nerd. Love having messages from people about things. So very much open to chat and collaboration. And thanks for listening this morning. And Josh, I'll hand over to you.
Awesome, thanks, Kat. That was great. Hopefully my slides are going to wake up here. There we go. You guys see what I've got? Is that working? No? Excellent. How about now? Yep, cool. Awesome. So bit of a shift of gears here. So as Kat alluded to, during my PhD, I was working in kind of the clinical space as well, working alongside Catherine and the team at Axis in the clinic, making some really interesting observations. And then at the end of my PhD, I was looking for a job, and I got the opportunity to move more into a neuroimaging space. But I've taken a lot of what I learned in the clinical realm and tried to bring that into the brain imaging of mTBI research domain. So that's hopefully what I'm going to cover in these next few slides. So it's going to go. There we go. So just a little bit of background. So we're in this small country in the middle of nowhere, and the community I work in is in one of the most isolated parts of this isolated country. It's a town called Gisborne, and I work at an independent research institute called mTBI Medical Research. And what our focus is, or sorry, before I get into that, we're a town of about 50,000 people, and we're 3.5 hours from anywhere. So we're extremely isolated. Our claim to fame is we're the first town to see the sunrise every day, and people mostly know us for high quality surfing and agriculture. But since 2020, a world-leading medical research institute focusing on advanced MRI opened here. And there's a whole background story into that I could share at another time. And our real point of difference is our MRI capability. So we do whole body, we do lots of different things, but our real niche is in the neuroimaging space. We've got top-class MR physicists and technicians, as well as the capability to do some pretty advanced post-processing. And a nice little fact that we like to share is our town only has 1 traffic light and has 2 MRI machines, and we're about to buy a second MRI at our facility, bringing that ratio up to 3:1 by the end of 2025. So while we're an independent research institute, we're heavily plugged into the major universities throughout New Zealand. For the sake of the work I'm going to discuss today, these are our main collaborators. And even though we're isolated down here, we've got these great global connections heavily in Australia, as well as at Stanford, University of Washington, and so on. So now getting into it. So why would we want to use advanced MRI to study mTBI or concussion? First of all, it's non-invasive and it's safe for longitudinal studies. So if we're looking at trying to investigate pediatric injuries or things like that, it's kind of optimal for those groups. In general, standard clinical imaging isn't sensitive to mild TBI. So even if someone's highly symptomatic and struggling, their standard images are going to look normal the vast majority of the time. There's a lot of different modalities we can use to quantify both brain structure and function in many different ways. And this gives the potential to establish an in vivo kind of ground truth. I think one of the issues kind of plaguing our field still is not having these kind of objective measures to then validate our more clinically fieldable tests off of. So obviously imaging isn't the only thing trying to plug this gap. There's the fluid biomarker work as well, but imaging definitely, I think, has a role to play in that going forward. And then what I'm going to mostly focus the rest of this talk on is these last 2 points. So we can use advanced MRI to investigate clinically relevant questions. So what's actually happening in the biology of the brain that might be explaining the symptoms someone's experiencing or why they are not recovering. And then lastly, I'm going to show how the power of how images can be intuitively interpreted by patients and kind of people in the lay public if they're presented in the right way. And that can really help us with tackling this injury in the future. So just at a high level, I'm going to run through some of the work that's been going on here. I'm not going to spend too much time on this, but I thought people in the special interest group might be interested. So I thought I'd just touch on it before I move on. So I've spent a lot of time the last few years building a big data set, looking at what I refer to as subclinical mTBI. Other people might call those repetitive head impacts, concussive, subconcussive impacts, whatever we want to call it. But trying to understand how participating in a collision sport, in our case rugby, and accumulating these subclinical head accelerations might affect the brain over time. And so we've been using instrumented mouth guards and advanced MRI, and we've been following a cohort of adolescent rugby players over the course of a season to try to tease out these relationships. And just to share a little bit of all the work that's gone into it. So this is just a diagram kind of showing the data we're sitting on at the moment, where we've had 3 full seasons of data with 88% retention of our participants. In total, we've got 86 unique players, with majority of those with multiple time points. 21 of these players, we have 2 full seasons of data on, so we can kind of do test retest of what we're seeing. Of these, 19 have at some point in the season had an acute mTBI and been scanned, and 13 of those we've had at least 1 pre-injury time point on, which is a really exciting little data set. So far, we've got 34 matched controls, and in 2025, the study continues where we'll be adding at least another 40 players, including our first group of girls, and some more controls to it. So I'll leave this there, but if people are interested, they can reach out to me or talk to me in Montreal. So now what I'm going to focus more on is clinical mTBI. So when there's been some sort of an event that has led to signs and symptoms that reach the threshold for diagnosing someone with a concussion or mTBI, and then how we're trying to use imaging to understand symptom burden and functional recovery in relation to what we see in the pictures. So somewhat of a similar design. People hit their head, they get a diagnosis, and then we do our best to try to get them in an MRI within about 7 to 10 days after their injury. And then we're trying to follow them up at about that 14 to 21 day mark, where, as Catherine alluded to, we think about 50% of people should be better, and then trying to follow them up again at that 8 to 12 week mark, where we think those numbers are, should be around 90% or so. And obviously just collecting imaging isn't enough. We're also capturing as much information we can about the actual characteristics of the injury themselves, what the symptom loads were, and then trying to do this kind of clinical phenotyping exercise. So then we can use that for subgroup analyses of the images. And so there's kind of 2 main centers where this is happening in New Zealand. Auckland is our biggest city. It's about the population is about 1/3 of the whole country. And so my mentor and collaborator, Mangor Peterson, has been working closely with Catherine and the Access Sports Medicine crew over the last few years, and recruiting individuals with acute sports-related mTBI. So these athletes get scanned about 7 to 10 days after their injury. and then a subset are rescanned after clearance to return to play. And those timelines generally align with what's outlined at the top there. And so far, there's been 50 acute mTBIs come through, and then about 25 of those have been followed up as well. And the really nice thing about this sample is that they're getting the wraparound support from Axis. So we can really we can feel confident that when they're deemed recovered, that for all intents and purposes from a clinical point of view, they're looking all right. And so we can start to look at the differences on the images of, well, someone who recovered in 2 weeks, how does their brain look different than someone who took 6 weeks to recover, and try to find those kind of biological signatures. In our Gisborne cohort, we're doing a bit of a different sampling. So we're just taking consecutive patients from our local ED and GP clinics. So these may be sports related, could be motor vehicle accidents, slips and falls. So it's going to be a bit of a more general sample. Again, trying to scan them as acute as we can, and we find that somewhere between 5 and 10 days is manageable with scheduling constraints. And then we're rescanning these people at about 21 days and 3 months post-injury. In our study, unfortunately, we don't have a clinical model that we can directly wrap around. So we'll use the symptom data and the other things to try to stratify people into recovered, not recovered, based on a number of methods that have been published in the literature. And at the moment, we've only got about 35 mTBIs and 30 controls, but we have funding to bring in about another 50 to 70 participants with 2 to 3 time points each. And we've just brought on an excellent PhD student who's going to drive this for us. So from our engagement with the clinicians, we think conservatively we can get about 1 new participant per week. And so we think by the end of this year, we'll be hopefully up towards 100 total cases. And so just going to share some initial findings that kind of relate to those points that I said at the beginning. So this is just a result that Mangor has written up with a subset of that Axis data set. And this kind of aligns with this idea of how we can use imaging to investigate clinically relevant questions. So Mangor took the functional MRI images, which measures blood flow throughout the brain to understand the connections of different functional connections of different regions to each other. And then he looked at how that related to people's symptom burden at their time of presentation to the clinic. And basically he found that there was moderate to strong correlations, particularly in the frontoparietal cortices of the brain with symptom burden. And an interesting thing that we found there is that the direction of that correlation depends on the anatomical structure. So it's not this homogeneous kind of linear response. It depends region to region in the brain. But basically showing that there's something here that is a signature that's saying, hey, altered or differences in connectivity in the brain are associated with worse symptoms. And I think that, with time will help us understand exactly what is that biological mechanism that's driving that symptomology. And then here, I just want to share a bit of a anecdote that I observed that kind of will hopefully drive home how we might be able to use images in the future to explain to our patients, why they might not be ready to return to sports or return to work. And so this kind of came from an observation I made when I was embedded with this rugby team we work with, where I was at a training standing on the sideline, and I overheard some discussions about these 2 players. So these are 2 young rugby players, both injured. One had an accident where they had fractured a lumbar vertebrae. They weren't too impaired. They were still mobile and didn't need any assistive devices, but they had a noteworthy injury, but from the outside in, they looked fine. The other player was 10 days following an mTBI and was still highly symptomatic, but these players were being treated very differently by their peers and people around them. So the one who had the broken back was being supported by his peers. Hey, don't rush back, take your time. You've got a bright future ahead of you. This is serious. You broke your back. Whereas the one with an injured brain was getting heckled for wanting to miss a game against tough competition, saying he was just making it up so he could kind of get out of a tough opponent. And the difference is that the player who had the injured back had a CT scan and an X-ray showing his fracture that he was showing to his peers, and they could actually see, hey, that doesn't look right. Like everything else is connected and there's that little crack there. So they could just look at it, and even though they aren't clinicians, they could see that doesn't look right. Whereas for our other boy with the mild TBI, everything looks normal. And so that was what I took away from that is this is the difference a picture can make if we can find ways to present it in an intuitive way. And so just going to present some early findings from a exciting case series. So we've been working with Emeritus Prof. Graham Bitter for the last couple of years. And Graham is a pioneer in neuroradiology. If you've ever heard of FLAIR imaging, which is one of the standard imaging techniques that are used all over the world, Graham is one of the key developers of FLAIR and who was involved in its rolling out to uptake just globally in this field. And so he's been working with us for the last 18 months or so on this new technique he's developed that he's calling ultra high contrast. And basically what it is it's an extension of FLAIR where the acquisition is slightly different and the math is slightly different, but basically it's the same ideas as FLAIR. But what we're seeing is we can get 10 times the amount of tissue contrast than what you would get in a FLAIR image. And so what I'm showing here is from a 17-year-old neurologically healthy athlete. The top image is a FLAIR, and what we're going to focus on in these images, if I turn my pointer on, you see my laser pointer? Yep. We're just going to focus on the white matter. So kind of counterintuitively, on these ultra high contrast, healthy white matter looks black like this, nice and dark. That's what we're looking for. And we started using this technique on some of our rugby players who came in with acute mTBI. And what we see is this very stark difference, this whitening of the white matter acutely post-injury. And we're calling this a whiteout sign. And we think that this might be kind of acute edema or a neuroinflammation that this new technique is able to pick up. And interestingly, this young player was really symptomatic at their time of scan. And then this is what we observed. Coincidentally, another player had an mTBI in the same game who played the same position, and we were able to scan him as well a couple days later just due to scheduling. But he was asymptomatic when he came in, and we're seeing this kind of healthy looking white matter like we saw in the control. And then lastly, this is one last case where we were able to get someone in who was actually scheduled to come in as a healthy control. And they actually hit their head playing a sport the night before their scan. And so they showed up saying, hey, I'm actually not feeling that great. I think I concussed myself last night. And so we got one of our doctors to look at him, and he was still happy to go ahead with the scan, but as a case rather than a control. And so we scanned him within 24 hours of injury. And again, we're seeing this kind of whiteout signature. And this one we were able to follow longitudinally. And at 64 hours post-injury, when he was saying he felt asymptomatic, we're seeing it moving back towards this healthy white matter sign. And then again, we were able to scan him at 2 weeks post-injury and seeing that same kind of signature. So it's only a small case series, and this is under review and should be published soon. But it's quite exciting that this might help us with that example I gave before, where we might actually be able to show someone, hey, you're still not right, and here's why. And so obviously can't conclude much from a case series, but since writing up that paper, we've actually brought in a lot more data. And so the next steps are the radiologists have developed this rating scale from 1 to 5, where 5 is that whiteout and 1 is healthy. And we're going to get our two radiologists to blindly go through scans from the data set I've listed on the right here and see how well we can actually pick out the acute mTBIs based on that whiteout sign and see how generalizable that might be in the future. So now just want to wrap up, because what led to this talk actually happening is I was catching up with Haley a while ago and talking about a systematic review I had done, and she said she thought it'd be relevant to this audience. So that's kind of what I'm going to finish my talk covering, which is, again, trying to investigate clinically relevant questions with MRI. And since working in this world, the number one question I get when I talk to clinicians is, cool, you got all these fancy imaging techniques. What can it actually tell me about my patient? How bad are their symptoms? How long is it going to take them to recover? Does it explain what types of symptoms they have? And I couldn't find the answer to that. So did a big old systematic review, which is under review and should be out in the next month or two, hopefully. So I'm not going to spend too much time on it, but basically we cast a really wide net. We weren't interested in any particular group of people with mTBI, so we included pediatric, sports-related, consecutive ED, basically anyone who kind of met the kind of American Congress of Rehabilitation definition, they were included. We weren't too particular about cause of injury, so we were trying to be quite inclusive. For our comparisons, as long as they had something to compare against, whether it was within data from themselves over time versus a control group or against normative data. And then our outcomes, the studies had to have at least one MRI modality acquired 2 weeks or less from injury. At the same time point, they needed to collect something to do with symptomology, quality of life, or functional recovery. And then there needed to be at least one follow-up time point with clinical data. So they didn't need to have multiple imaging, but at least multiple clinical assessments. We didn't include studies that just focused on neurocognitive outcomes because it was just outside of the scope of what we were interested in doing. And we screened almost 7,000 articles, so that took quite a while. Went through 136 full texts and ended up landing on 52 studies in the end. And before even digging into the results, there was a clear takeaway to me, which is we had to exclude almost 150 studies because they just didn't include any sort of measure of recovery, of symptomology, of quality of life. And so our understanding of these relationships could be so much more advanced if these studies had included these free, easy to do, quick tools in their projects. And as someone who works in imaging, this is expensive. So this represents hundreds of millions of dollars probably that didn't actually get us any closer to understanding how the images explain the clinical presentation of the patient. And so there was kind of 6 main modalities included in the study. The 2 primary ones were diffusion weighted imaging, which measures white matter and the microstructure of white matter, and then functional MRI, which measures these functional relationships between different brain regions by measuring blood flow. From the clinical assessment point of view, probably unsurprising to people who are going to tune into this, is it was highly heterogeneous across the measures used. So there's 17 total instruments used to measure symptoms. Some studies did phenotyping, but they did it in a lot of different ways. Only a handful of studies looked at quality of life. And recovery status was the thing that was evaluated the most often, but how this was defined was quite variable as well. So there's a couple key takeaways to pull away from this. One was there are divergent findings on imaging based on actually what the participant's outcome was. So one example was acutely we saw increased FA, which is a measure of the white matter integrity, in those who experienced normal recovery, so within kind of that expected 2 to 4 week time frame. Whereas acutely there was decreased FA in those who went on to develop persistent symptoms. Similarly to that, there was also divergent findings when looking at both structural and functional connectivity, where when people who had normal recovery were compared versus controls based on their acute imaging, there weren't really any differences detected. Whereas when that same comparison of acute imaging was done for people who had persistent symptoms versus controls, differences started to emerge. And so kind of the main takeaway that I extract from this is, in neuroimaging investigations, we need to adopt methods that embrace the known heterogeneity of mTBI rather than assuming that these are heterogeneous groups. So what I showed with that FA result, what I think is happening there is oftentimes the results in the neuroimaging literature are unclear. But if we actually have these 2 separate subgroups that with different trends and we average them, they're actually canceling out that meaningful effect and making it harder to detect relative to a control group. The next big takeaway was that the main anatomical areas of interest that were associated with recovery were not these focal regions, so not strictly vision related or vestibular related or higher level cognitive or anything. The ones that showed up the most common across the studies were these kind of multifunctional hubs in the brain. And so the ones that we saw the most often were the cingulate cortex, superior longitudinal fasciculus, and the thalamus. And so the takeaway from this was that these disruptions to these multifunctional waypoints that are in charge of integrating and relaying complex information from different sources are implicated in mTBI recovery rather than focal disruptions at a group level. So maybe that's where we need to look. And with what we know about this injury of it being diffuse and non-specific, this kind of fits that model. And then finally, I won't spend too much time on this, but the last takeaway was we need to embrace complexity when we're studying this. And one of my kind of nerdy things that I'm into is trying to move towards biological systems approach of understanding things. And with that, the main idea is the forest cannot be explained by studying the individual trees. So we can't understand the complexity of how a brain responds to injury just by looking at one imaging modality, one clinical test, one fluid biomarker. There's going to be overlapping complex relationships, and we need to find methods to embrace those. And so I won't go into that too much more, but one of the presentations I'm delivering in Montreal is about how we can do this quantitatively. So if you're interested, come chat with me then. And so last thing, because I've got to wrap up here, is I know there will be people listening to this saying, yeah, but MRIs aren't accessible, so whatever. And I totally acknowledge that. Routine MRIs at scale with mTBI is going to be very difficult. There's no way of getting around that. I think what I showed with that ultra high contrast might be plausible because that can be done on any machine that FLAIR is done on. Accessibility will still be an issue, but it doesn't require fancy post-processing and acquisition systems. But then the more advanced techniques that need all that additional processing power or sophisticated tech might be suited for advancing our clinical knowledge, where we don't need to necessarily directly measure every patient, but we can make these discoveries that can then inform clinical decision-making, or we can validate tools like what Catherine's talking about that can be deployed in the clinic. And we know that if that tool shows us something, that is actually related to what we see on the images. And so we can make confident inferences based on that. And so with that, I just want to recognize the awesome collaborators I have and everyone who's funded the work that I presented today. And if we have any questions, we'd be happy to hop into those.
Thank you so much, guys. That was incredibly informative. I always love talking to you guys about your specialty in research because you guys are such experts at what you do. But yeah, if anybody here has questions, feel free to either raise your virtual hand by using the reaction in the bottom Zoom toolbar, or you can go ahead and pop a question into the chat. Either is fine. But to get us started here, I'll actually ask a question first to Catherine. And I wanted to talk a little bit about cognitive subtypes for concussion. I think the work you're doing in terms of exertion is very necessary, very interesting. And I'm assuming that since you didn't find anything in the cognitive subtype, it was because it probably wasn't reported. But I wanted you to dig in a little bit more and think about, what would your expectations be for pre-post exertional cognitive tests in concussion, and whether or not those would have similar values to those other autonomic and vestibular examinations that are a bit more common.
Yeah, I think it's a great point, Haley. And I should probably note that when particularly that first paper was published, we weren't collecting cognitive assessment data with any kind of tool. So, we were using the SCAT basically. And so now that we've rolled out Cognogram throughout the clinic, that should be really interesting. But, as you'll be aware, there's several studies showing that about 30% of people will fail a cognitive assessment post-exertion in an mTBI population. And that was really the kind of starting point for me. I was like, well, if that happens in the cognitive space, then I'm sure it happens in the sensory motor space too. And yeah, my view is that we have some established tools in that area that I think are quite accessible, Cognogram being a good example, but there's versions on the same theme, impact or whatever, I think it's really, really important. And it speaks to a big piece of the risk puzzle when we're looking at return to sport, if they're having a bit of a cognitive issue after exertion, for sure.
Yeah, absolutely. And I know that some other studies have recently started using cognitive exertion as the exertion piece too, which I think is really interesting, especially for that return to learn population. I do see that Alyssa has her hand raised. Alyssa, what is your question?
Sure. So I have a question for Dr. McGeown. Is that how you pronounce it? Okay. So I noticed, or I saw what you were saying about how you are looking to implement this into like pediatric cases. How you were like in the initial part of your talk, the frontal and the parietal lobe, how you were thinking. So, one question that I had is, we know that the frontal lobe doesn't really develop until people are much older. And it's also variable, the stages of life at which this develops and kind of an individual thing. So, do you think that there's any way that that could be, impacting, say, this person's brain scan is, even if the child is the same age, maybe this is not necessarily they're experiencing this difference in imaging because of their age, but maybe or sorry, not because of their concussion, but maybe it's because compared to other children this age, maybe their like brain isn't, or their frontal lobe isn't as developed or something in that regard. I was just curious of your thoughts on that.
Yeah, it's what makes trying to study adolescents, especially adolescents who are participating in sport, because we know sport and physical activity has profound effects on the brain and how it develops. So yeah, it's a real kind of piece of the puzzle that we're trying to tease out in that kind of subclinical work I talked about. It's something that we're really trying to figure out how we interpret our findings, because is this growth? Is this the effect of physical activity? Is this the effect of hitting your head? Is it an interaction of the three? It's difficult to parse. How we're trying to tackle that is our control group at the moment is, more or less representative of the age range that we're looking at. But they've only got one time point. And so what we're moving into this year is longitudinally scanning some of those controls so we can try to say, all right, this is what we think a kind of normal growth curve, or the range of what kind of normal ish looks like in this group, at least in our population. And then trying to use that as a band and saying, okay, if we're seeing things significantly outside of that range, and then if there's an association with symptom load or some of these other measures or indicators, then we feel more confident attributing that to potential brain trauma. Whereas if we're seeing that there aren't those relationships, then I think concluding that, hey, this might be physical activity related or age related or whatnot, is a more plausible explanation. So short answer is it's complicated, but we're putting processes in place to try to tease those relationships out.
Got it. Thank you.
Great, thank you for that. Additionally, while we're still talking to Josh, I know we only have a couple of minutes left. I just wanted to point out a few things in your presentation that I thought were particularly interesting, not necessarily questions, but just things that I found unique. One of the things I noticed in your presentation was that work-related falls population that you have when you were discussing that upcoming project that you guys are doing. I am very excited to see the results of that project, because your population that's non-sport related is very different from what we see here in the United States. And that's very likely because of insurance and how we route people through care. We had a study come out not that long ago, and Jake McPherson, Catherine mentioned him earlier, was the lead author on that, where we found that people with non-sport related injuries were getting to us in a median time of like 3 to 4 months. So they're already so long into persisting and prolonged symptoms that they're a very different population, whereas getting them earlier and seeing what early intervention might do is going to be so important. So I'm very excited to see the results of that study whenever they come out.
Yeah, and I think one comment I'll make as well that creates a really unique environment for the work Catherine and I are doing in New Zealand is in relation to ACC. The ACC model eliminates liability and litigation claims because ACC just takes care of it. So you're not getting caught up in the, well, I had an accident, can I sue this person? And then that's kind of making it very murky with, is this person in my research for good intentions, or we just don't really have that challenge here. So access to care is there, but we're not also worried about what might actually be a motivating factor kind of in the background of this person recovering or not recovering. So that creates a really unique landscape here. Do you have anything to add to that, Kat?
No, I was just going to say, I mean, we've seen our clinical cohort that presents to our clinics shift quite a lot, Hayley. So we see a lot more of ACC referrals as opposed to in non-sport. So it would be probably 30 or 40% now of our presentations. And so some of the lessons from that is really interesting. And we're continually kind of evolving our clinical processes, because obviously we'd like to get people early, but that's just not the reality of what happens even in a well-functioning medical system. And in New Zealand, access to GP appointments is really, people struggle to get in with their doctor for like a month. And so then we have a lot of those delays too. Yeah, for sure.
Yeah, absolutely. And that's what makes our body of literature so strong, is the diversity between all the groups and the clinics that we have. But with that, we are now past the hour. So I wanted to thank everybody again for joining us. This presentation will be recorded and uploaded for later use if you'd like to do so. Additionally, I'd like to encourage everybody again to join us in Montreal in March the 19th to the 22nd. We will be having a SIG meeting there, as I mentioned at the top, and we'll be taking ideas for new webinars. We usually host a couple every year. So if you are around, we'd love to hear from you. And with that, thank you guys all for joining, and we hope to see you next time.
Thanks, Hayley.
Thank you.
Thank you
Ka kite,
guys.
everybody.
Bye.